Good evening. My name is Michael Whitley. I am a ASCP certified MLT. I am currently in pursuit of my bachelor's in clinical laboratory science at Winston-Salem State University. And today I will be presenting my research into a study on massive transfusion protocols and the effects it has on the laboratory and trauma patient outcomes. During this presentation, we will discuss hemorrhage, massive transfusion protocols, comparisons of trauma patients who utilized massive transfusion protocols and those who did not, the effects of massive transfusion protocols on the lab, further research, and we would conclude with a few key points. Trauma is the leading cause of death in the United States, with hemorrhage being the second leading cause of all fatalities of trauma patients. Hemorrhage can result in hemorrhagic shock, which reduces oxygen saturation and oxygen delivery to vital organs. Hemoglobin values of less than 7 are considered critical and require intervention by blood transfusion. And massive transfusion protocols regulate these blood products and manage the requirements needed for massive blood transfusion implementation. Hemorrhage is a term used to describe massive blood loss, usually in cases where at least 15% of the patient's blood volume has been lost. Some causes of hemorrhage include blunt traumas such as car accidents or physical assaults, penetrating traumas such as gunshots or stabbing wounds, crushing traumas such as a heavy object falling onto the body. Hemorrhage in combination with the tissue damage can result in stimulation of the immune system, which can cause something we call a lethal triad, which consists of coagulopathy, metabolic acidosis, and hypothermia. A decrease in oxygen transport throughout the body can result in cellular destruction and anaerobic respiration. This increases the amount of lactic acid in the patient's body, which gives us the acidosis. The acidosis, in turn, reduces the heart's performance and the ability of the body to circulate blood, decreasing the patient's body temperature, giving us hypothermia, which in turn gives us decreased coagulation, and then coagulopathy. The cycle continues, and then we have the lethal triad. Massive transfusion protocols are important for rapid response to massive blood loss, achievement of hemodynamic stability of the patient, restore tissue perfusion and oxygen transport to the body to prevent further organ damage and prevent the lethal triad. A standard for massive transfusion protocols has not yet been established. Hospitals create their own policies and procedures based on what the current knowledge is. Some of those requirements for massive transfusion protocol activation include a hemoglobin of less than 7 in an actively bleeding patient, access to the proper care team, such as prompt access to physicians in related fields based on the type of trauma. For instance, a cardiac, a generalist, neurology. The hospital also needs prompt access to blood transfer from outside the hospital in cases where the blood supply may get low due to massive transfusion protocol. The hospital needs to be considered a trauma hospital. And in cases where the foresight that the patient might need more than 4 units of packed red blood cells per hour or greater than 10 per 24 hours. Some factors that you want to watch for during massive transfusion protocol implementation is the patient's coagulation studies such as PT and APTT, the patient's clinical state, hemoglobin and platelets, transfusion reactions, and another key factor is that in patients during trauma incidents, they're not able to metabolize citrate, which is in the packed red blood cells as a citrate-derived anticoagulant. This can build up in the patient's body and become toxic. So we need to make sure that we monitor the patient's calcium level for hypocalcemia. In regards to the optimal transfusion ratio, packed red blood cell to fresh frozen plasma to platelets has a common ratio of 1 to 1 to 1. At a local hospital where apheresis platelets are used, a 6 to 6 to 6:1 ratio of packed red blood cells, fresh frozen plasma, and platelets was used. In some comparisons of massive transfusion protocol and non-massive transfusion protocol in relation to trauma patients, we have a case here where there were 58 trauma patients who experienced traumatic hemorrhage. 16 patients had massive transfusion protocol activation. 14 patients unfortunately passed away due to their traumatic injury. Of the 14 patients, we had 4 of the massive transfusion protocol group that died, 2 within 24 hours, 2 before the 30-day mark. They had an initial hemoglobin average of 10.4, a longer length in the hospital, which was linked to the severity of their trauma. In relation to the non-massive transfusion protocol groups, 10 patients died. They had an average hemoglobin of 11.6. 5 died within 24 hours, and 5 more died before reaching the 30-day mark. What we can see here is that the massive transfusion protocol group had fewer deaths overall compared to the non-massive transfusion protocol groups. They also had a higher severity of trauma. So the massive transfusion protocol was able to decrease the mortality for that group. The next case, we had 95 patients who activated massive transfusion protocols. 71 survived to the 24-hour mark. 65 survived to discharge. We had a survival rate of 68.4%. We can see that of the 65 survivors, there was a variation in the length of stay in the hospital, whether they were in ICU or on a ventilator. We also know that there were some influencing variables. 4 of the surviving patients had a hemoglobin less than 7 and received 2 or more units of packed red blood cells within 1 hour. 1 of the non-survivors had a hemoglobin of less than 7 and only got at least 1 unit of packed red blood cells within 1 hour. So prompter access to red blood cells and the quantity of packed red blood cells was a variable that increased the survival rate. Also, the type of trauma, whether it was blunt or penetrating. The next case, we compare blunt versus penetrating. We had 1,278 trauma patients. 733 were blunt. 554 were penetrating. The blunt trauma had a higher percentage of death at 59.35%, where the penetrating had 45.32% of their population. Some predictors for mortality include the need for more units at the 4-hour mark, initial hemoglobin and platelet values, And there was also a decrease in mortality was noted when more units were transfused. As for the effects on the lab, there is an increased workload in relation to the tests ordered on the patient. For chemistry, you have calcium tests that are going to be routinely ordered to monitor for hypocalcemia. In hematology, you're going to have CBCs ordered to monitor that hemoglobin and platelets, coagulation studies. Blood bank, you're going to have type-in screens, cross matches, potential reaction workups. Again, stated earlier, some of the effects on the patient is the variable in the length of stay. With massive transfusion protocol activation, it is suggestive of a shorter length of stay in some cases. That also depends on the severity of the injury. There's less post-discharge complications. Some of the other negatives is that there is a potential for sensitization of antibodies. We're not always able to get type-in screen in before patients in traumatic situations start being transfused, so that puts them at risk of having reactions or being sensitized to antibodies. Or there's also the increase for iron overload due to all the units that are being pushed into the patient's body. Further research should focus on the trauma patients who had massive transfusion protocol activation and those did not. The patient criteria for the research should include patients that are greater than 15 years of age, were alive when they reached the hospital, had trauma that involved massive hemorrhage, that included a blunt, penetrating head trauma or crushing trauma. Data should focus on the 24-hour and survival to discharge rate, the amount of time the patient spent in the hospital or ICU, or the time the patient spent on the ventilator. Initial test results such as hemoglobin and platelet counts. Should also focus on the laboratory workload in comparisons to chemistry, hematology, and blood bank when massive transfusion protocols are utilized and when they are not. In conclusion, massive transfusion protocols from the research have shown positive benefits: faster stability of the patient, shorter length of stay. The best outcomes are seen when a 1-to-1-to-1 ratio is used. Whole blood has also shown to be a valuable option for massive transfusion protocols. Blunt trauma shows a higher mortality rate compared to penetrating traumas. Research is variable. Further research should be done to compare the MTP activation in non-MTP groups. And attention should be paid to the length of stay, initial laboratory values such as hemoglobin, clotting factors, platelet counts. Thank you.